morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences of ACNS webinars in different parts of the world. Welcome back to yet another episode of very educative lectures for you. The speaker for the first session of today's webinar is our honored guest from the USA, Professor Adnan Siddiqui. Professor Siddiqui is a professor and vice chairman in the Department of Neurosurgery at the State University of New York, at Buffalo's Jacobs School of Medicine and Biomedical Sciences. He is a dual-trained neurosurgeon with expertise in both open and endovascular neurosurgery. His areas of special interest are in the management of cerebrovascular conditions like aneurysms, AVMs, and spinal and cranial dural AV fistulas. He has also a special interest in the management of ischemic stroke and endovascular management of intracranial and extracranial vaso-occlusive diseases. He has also been a principal investigator for several trials till date. Professor Siddiqui has authored over 450 peer-reviewed publications and more than 50 book chapters. He is an invited faculty to various international workshops and conferences and has given more than 200 international lectures till date. We are extremely honored to have him today as a speaker at our webinars, and today he will be talking about time to treatment and stroke outcomes in large vessel occlusions. The speaker for the second session of today is our honored guest from China, Professor Mingxing Zhu. Professor Zhu is the Associate Professor, Deputy Chief Physician in the Department of Neurosurgery, Tongji Hospital of Huachong University of Science and Technology, China. He is a committee member of the Neuroregulation Branch of the Chinese Stroke Association, Executive Deputy Team Leader of the Neurointerventional Group of Cerebrovascular Disease Committee of the Hubei Pathophysiological Society. He is also a committee member of Neurosurgery Branch of the Wuhan Medical Association. He is a dual-trained neurosurgeon with clinical interests focused on cerebrovascular neurosurgery. He is also a noted author with several publications. He is an editorial board member of the Stem Cell Research Therapeutics. We are extremely thankful to him for accepting our invitation to be a speaker at our webinars, and today we will be talking about endovascular management of dissecting posterior circulation aneurysms. The chair for the first session of today is our distinguished faculty from Japan, Professor Shigeru Miyachi. Professor Miyachi is a professor and director in the Department of Neurosurgery, Neuroendovascular Therapy, Aichi Medical Center, Aichi, Japan. He was the president of the Asia-Australasian Federation of Intervention Therapeutic Neuroradiology and the past president of AFTIN Congress in 2012 and vice president in 2014 and 15. He is a noted author with several publications in various periodic journals and also has received several awards, including the Best Doctor of Japan award in the past. We are extremely thankful to him for accepting our invitation to chair the session of Professor Adnan Siddiqui. The chair for the second session of today is our honored guest also from Japan, Professor Yuichi Morufuji. Professor Morufuji is a chief neurosurgeon in the Department of Neurosurgery, National Nagasaki Medical Center, Nagasaki, Japan. He was a previous senior fellow at the University of Washington, USA, and his practice specializes in the microsurgical and endovascular treatment of aneurysms, AVMs, dural AV fistula, strokes, carotid artery stenosis, and brain tumor. He is passionate about basic translational research focused in blood-brain barrier and has been principal investigator in several basic international research projects. We are extremely honored and thankful to him for accepting our invitation to chair the session of Professor Mingxing Zhu. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to welcome both the speakers, chairs, and the audiences to this online platform of his ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely thankful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Boon Seng from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Shigeru Miyachi.
Thank you, Raja. It is a great honor for me to chair the first session by Professor Adnan Siddiqui. He's my good friend, and it is a long time to see him again now because of the COVID trouble. But now it is a very good trend lecture. His title is "The Time to Treatment and Stroke Outcomes in Large Vessel Occlusion." He has a lot of experiences of this mechanical thrombectomy, and also the good system in US for to improve the outcomes. So we are we are looking forward to listening his lecture. So, Anna, are you ready? It's okay?
Yes, I am. With your permission, okay. Thank you very much. I'm Shigeru. This is lovely to see you. It's been a long time, as we were talking about, and I hope we can be together at WFITN. I look forward to that as well. And this is an honor, and I'm honored to be with this distinguished faculty and Professor Raja. Really appreciate the invitation. So the task you've given me is to talk to you and your audience about the time to treatment and what is its value, because we have heard a lot of different things about time. Time is very important. You need to do it with the first 3 hours initially, remember, with thrombolytic therapy. Then it went to 4.5 hours for thrombolytic therapy. And the mechanical therapy, we thought it was 8 hours, but then the trials did 6 hours, then they went to 12 hours and 16, 24. What is it? So what I'd like to do is today take you through the data that lays it out in a fashion that hopefully your audience will appreciate. Here are my disclosures. I have a lot of disclosures in the endovascular space, but I believe none of the material I'm presenting today is in any way conflicting with any of these disclosures. So this is a beautiful study which really started that entire, a beautiful editorial by Steve Levine, a stroke neurologist in New York. And he described the time man had cometh to brain, tick death, a little poetic expression that really a little bit of time is constantly melting away as the person suffers a stroke with the brain, as beautifully demonstrated in this figure. And then Jeff Saber, soon thereafter, really did a fantastical description to create a reflection of the magnitude of the importance of time by creating an estimates of numbers of neurons, synapses, myelinated fibers, which are lost per stroke, per hour, per minute, per second while having a stroke. So again, estimating that these were the time or strokes. So let's just go over a few concepts. What we know about the stroke pathophysiology is that rate of neuronal loss is not absolute. There are principally two big categories. There are fast progressors and there are slow progressors. Almost the majority, 55%, are slow progressors, and about 25% are fast progressors. However, the infarct growth rate is dynamic and it's continuous spectrum. And there are certainly intermediate progressors. And there are people who start off fast and then go slow, and some start slow and go fast. So it's a dynamic process. And predictions of infarct growth are still not quite clear, but we believe one of the most important ones is the collateral blood flow. That's one of the biggest factors that we realize. And then there might be some innate resistance to ischemia factors that are also important, such as ischemic preconditioning and other concepts such as that. So what this means is that you start off with a penumbra, but that conversion to infarct is dynamic and occurs in the context of significant individual variability of leptomeningeal collateral grade. And that's what determines your final infarct volume and explains fast or slow infarct growth. So fast progressors, you have to intervene as soon as you have a diagnosis, because the problem is the infarct volume will be achieved much more rapidly in a fast progressor than in a slow progressor. So if you're trying to do the standard therapy for LVO onset and diagnostic imaging, you might have very little time to help a fast progressor while you have a lot of time for the slow progressor. And we believe most of this is determined by the collateral blood flow, which is in most MCA cases, these collateral arterioles between the ACA and PCA, which are dilated to allow flow into an MCA branch, which is supplying the penumbral tissue. So what we have realized is that when people have looked at the collateral grading, and there have been lots of different ways of looking at CTA, CTP with MITEF, David Libeskind and his work with cerebral angiography, and Menon with CTA as well, you can see that the likelihood of a fast progressor getting an MRS, modified Rankin score of 0 to 2, or minimal disability score, is almost 0% with poor collateral grades and 47%. And similarly, in every scale, because the thresholds are different, you can see that same improvement of good outcome from 28 to 66 and 18 to 57%. And what this means is if you translate this to the same data that Jeff Saver did, is that fast versus slow progressors can result in a massive difference in the amount of injury that is being suffered, where slow progressors might be losing neurons in the thousands, whereas fast progressors are simultaneously losing neurons in the millions. And similarly, what this important step means is it's really important, not just from stroke onset to presentation to the ER, but to triage and transfer, to the in-hospital workflow, to neuroimaging, to treatment. All of these factors play a role. So let's take a look at it slightly differently. So let's assume we have 24 hours for all fast and slow progressors to open up based on the literature that we have right now. What you realize is when in the first 6 hours, most are fast progressors, but when we go to later time points, very few are fast progressors because most of them have already completed infarctions. And this is now beautiful work done by Ashutosh and team with Tudor and everybody else, which really shows that the infarct growth rate really is one of the most important predictors of stroke outcome. So let's just take a look at a few examples. Here is a patient who comes in with global aphasia, NIH of 24, left hemiparesis, and the CAT scan looks reasonably well preserved initially. There you can see this left-handed individual with a right hemispheric IC occlusion. There is the initial perfusion study. Here's the flow, here's the volume. There's almost none. And so it's amazing that your aspect looks this way. This is rapid, giving you a total CBF at risk of 260 and 300 plus cc's of highly at risk tissue. You can see this is a occlusion of the carotid. There you can see there we cross. We have a solitaire stent retriever, and this is the result, which looks excellent. So we get first pass recanalization, we stent the carotid. This is the result. And so despite a relatively early presentation with relatively reasonable aspect, this is a fast progressor. And the patient NIH of 17, modified Rankin score of 5. Here's another one. Last known well in an hour and a half ago, NIH of 24. There is an M1 occlusion. And there you can see it is completed again with completed infarct, despite the fact that the patient had very early presentation. Let's look at this case. NIH of 14, 30-hour onset. Volume and flow are well preserved, which is an example of the collateral score. The patient still have a deficit of NIH of 14. There you can see on time, there's significant increase. There's the M1 occlusion. There's solitaire. There's recanalization. This is the result. NIH of 0. And despite small infarct, that is still there with MRS of 0 at 90 days. So this is an example of a slow progressors. So guidelines have continued to evolve in this fashion as well. So initially, we look at the Hermes trials, which were the slot of 2015 5 trials that were published relatively in quick succession around the International Stroke Conference in Nashville, and 1,287 patients. Number needed to treat was 2.6 for improvement of 1 point on MRS. And essentially every pre-specified group had a very significant signal in favor of intervention. So initially, the concept was treatment can be initiated within 6 hours of some symptom onset, we should do it. Beyond 6 hours, it's a little uncertain. But then came Diffuse 3, which looked up to 16 hours and again showed very significant benefit for thrombectomy group compared to control, with even a mortality signal and no significance in the difference in symptomatic intracerebral hemorrhage. And then we had Dawn, which went all the way to 24 hours by Raul and Tudor, which looked at NIH of greater than 10 with very specific mismatch volumes and an even greater benefit, 49 versus 13%, with no difference in intracerebral hemorrhage. And so new guidelines came out that revised the previous one, which went from 6 to 16 and then 16 to 24, which really were the new recommendations. And so now in patients without large core infarct, indication is up to 34. And then just this past month, our wonderful colleagues from Japan really did this phenomenal work, which really opens up the door to this different population. So endovascular therapy for acute stroke with large ischemic region. And in this group as well, clear benefit in favor of endovascular therapy. This was up to 24. Now, this is the first trial. It has not changed the guidelines in the US, but I am sure they will change because we have multiple trials in the United States looking exactly at this. We have Tesla, which is going on, led by my friend Sam Zadat, who is well on its way towards completion, and it'll be very interesting to see what that trial shows. So now, keep moving from the data standpoint to what it really means. So this is just a wonderful example of what it means for endovascular therapy for stroke. This is based on data from Helsinki and Mr. Clean. And essentially, each minute saved in onset to treatment time generated a 4.5-day extra healthy life. And this is quite significant. So patients younger than 55 with severe strokes gained more than a week per each minute saved. And so 20 minutes saved led to 3 months of disability life. And so this is just very nice examples. Now, this is data from Europe where they looked at 1,287 patients, and they looked at when they actually showed up for treatment. Those who were faster than 240 minutes and those who were slower than 420 minutes. And it's quite impressive to show that the fast group had a far better good outcome than the slow group. And so this was the totality of what was being done. These are not fast progressors, slow progressors. These are all in one group. Just based on when they showed up to the hospital, you were much more likely to do better. This is a German stroke registry, 25 centers. And this is, again, starting to get very close to where we are now. This was looking at door to groin time. So this is no longer when the patient had the stroke. This is now patient has had the stroke, patient has come to the hospital. Now you're responsible. How long are you taking from the patient getting to your door to intervention? And delay in door to groin time was associated with unfavorable outcomes at comprehensive stroke centers of 1.3. That was the odds ratio. So there was a 30% increase in poor functional outcome per hour of door to groin time. So a 30% decline in good outcome. This is, again, wonderful data from my Japanese friends of impact on procedure time. So not just door to intervention, but actual intervention. 1,247 patients, large number, and a 30-minute delay in procedure time meant a 24% decline in favorable outcome. So an odds ratio of 0.76. And again, what this means is that the longer you take in the hospital to get them to the cath lab, and the longer you take in the cath lab to get them open, also are predicting poor outcomes. This is data that has come out. This is by my friend Quill Turk and Ray Turner when they were still at MUSC, and they created this data which demonstrated that there was a golden half hour of stroke intervention. And this was true for the ADAPT technique, which is aspiration first, that the likelihood of a good outcome was much better if you were in this early recan group than if you're in the late recan group. And so this is very congruous from the data that I have demonstrated before. And when you look at the impact of procedural time and angiographic outcomes in acute stroke, there's Amir Hassan and Jeff Saver, Mayank and David. They really looked at data from SWIFT and STAR and SWIFT Prime, large trials and registries, 300 patients. The rate of favorable outcome was significantly higher when the procedural time was under an hour compared to more than an hour. And when you looked at predictors of unfavorable outcome, onset to groin puncture was highly significant. Groin puncture to recanalization was significant, but not as significant as onset to groin puncture. So because it's a smaller piece of the puzzle. And I think this makes a huge impact when you start thinking about all the different relationships and indications. So interestingly, when they looked at incidence of hemorrhage as a function of recanalization, that also increased with a delay. So when you look at recanalization time group, the higher the time to recanalization, the higher the PH2 percentage as well. Again, suggesting a direct correlation with increase in risk. And similarly, early recan group has a much more likelihood of MRS of 0 up to 20% and MRS of 1 to 2 all the way up to 70%. So I think this is an important figure to keep in mind, that these are all patients that are getting recanalized, but doing it slower, taking longer, has an immense impact on intervention. And this is, again, a very good paper that describes a probability of functional independence in 90 days by procedure time. And you just look at the examples here. When you look at the modified Rankin score, you can see this trend where you can imagine that if the groin puncture to recanalization time is in the 5 to 10 minutes, your good outcome range is in the 60 to 80%. Whereas if you're taking 200 minutes, they have some groups, they have spread, but you can see most of the patients are not going to get beyond mid 30%. And look at how this really curve changes. The procedure time is less than 60 minutes. You have a huge difference between MRS of 0s, MRS of 1s, and MRS of 2s. Is essentially in every category, you can see there's a big discrepancy with more number of patients in the higher group than in the lower group. So this is a paper I just want to take a little bit more time. This was done with meta-analysis, again, of the Hermes group led by Jeff Saver and Mayank, which looked at the time to treatment of endovascular thrombectomy and outcomes, a meta-analysis. These were all rigorously conducted studies, and thrombectomy, they noted, up to 7.5 hours was associated with improved outcomes. It's interesting. This is, before any specific perfusion-based selection for the diffuse and DAWN trials. And what was interesting is rates of functional independence after thrombectomy were 64% with reperfusion at 3 hours versus 46% with reperfusion at 8 hours. So let's just look at this data. This is association of 1 hour treatment delay with disability level, functional independence, and mortality at 3 months in the thrombectomy versus medical groups. So remember, this is the Hermes trials. And what you notice is symptom onset to randomization interval did not really make a big difference between medical and thrombectomy. There was no significant difference. Symptom onset to arterial puncture also was not that significant between arterial or venous puncture, MRS, all of this was safe. Symptom onset to reperfusion time starting to get significant. And so if you were able to open up, the sooner you did, the better it was. Symptom onset to ED arrival time was not that significant. Again, you're comparing endovascular with thrombolytic therapy. However, once you got to the ED, how long you took to randomize between endovascular and medical made a huge significant difference. ED arrival to arterial puncture made a huge significant difference. ED arrival to reperfusion made a huge significant difference. So what this is suggesting is that our in-hospital workflow has a massive impact in the outcomes of these patients. And so look at this chart that they generated based on the 2015 trials. You know, we are farther along now, but this is good because perfusional imaging was not a big part of this model at that time. So we are not really separating fast and slow progressors. These are all comers in a variety of different geographic regions around the world. And what we can see is the association of time from symptom onset to actual reperfusion among patients in the endovascular group achieving substantial reperfusion. And you can see is that time from symptom onset to reperfusion. So here you have 3 hours. Here you have almost 7 hours and 8 hours. And when you look at these groups, you can clearly see the faster the recant time, almost doubling of good outcome with no disability, MRS of 0, and similarly 16 to 25. You can see this massive difference in the overall good with 0 or no disability or minimal disability and modified Rankin of 2. Again, you can see a massive difference. I think this is really important to keep in mind that this is the impact of in-hospital delay. This is another way of looking at it, that when you look at the likelihood of where you're going to be with percentage of patients by MRS range, you can see that as you get farther out, the range variability really starts declining in favor of more patients in the 0 to 5 range as you get farther out. And the 0 range and the 0 to 1 range continue to decline, and most patients end up in the higher category with time. So a nice pictorial description of that. And so this is what I take away. This is really the summary figure that I would like for you to appreciate and understand is the relationship between in-hospital treatment speeds and functional independence among direct arrival patients in endovascular therapy achieving substantial recanalization. So sticky 2B and 3, and we're not talking about 2C and 3 reperfusion, which is where the field has gone since. If you show up within 2 hours and get recanalized within 2 hours, functional independence by time from emergency department arrival to actual substantial reperfusion. If you get it within the first hour, you're getting to close to 90% independence. And when you go down to 6 hours, this number is down to 30%. And what that means, what that translates into, is that every 15-minute reduction in door to revascularization. So this is not door to cath lab, it's door to revascularization. For every 15-minute reduction, there's a 2.5% increase in functional independence of patients with LVO. So every 15 minutes is costing somebody 2.5%. So 1 hour delay is a 10%. 2 hour delay is a 20% cost to the patient. And I think this is, you can see a similar pattern from brain imaging to acute revascularization. But this is really my take home is At 2 hours, it's 90%. At 6 hours, that's 30%. And I think this is really, really, really important. So in conclusion, time matters in all patients. It matters most in fast progressors, but it still matters in slow progressors as well. And it's not just time of onset to presentation in the emergency department. It's time from the emergency department to imaging. It's time from imaging to arterial access. It's time from arterial access to recanalization. It's time of onset to recanalization. All time matters. And the effect of time is dramatic because you can achieve up to 90% good outcome within 1 hour from arrival and 30% when it's 6 hours from arrival. So I think this is all very important for us to appreciate that time is of absolute critical importance in all cases of large vessel occlusion. Thank you very much. I appreciate your attention, and I hope this has been useful. And I would love to engage in discussion now based on these slides.
Thank you, Adnan. So it is a very nice lecture, and we can understand the importance of time for the large vessel occlusion. Yeah, it is a very complex lecture, and so it is very big impact. So we open the discussion, and do you have the comments or question from the audience?
Co-host Libun Singh, any questions?
Yeah, thanks, Raja. Thanks, Professor Adnan, for very nice presentation. I have a 3 questions may related to the slides, but maybe out of the scope. First question, Professor, do you think that a patient with a chronic arteriosclerotic, we have more chance to have the collateral circulation and less chance to have a fast progression? Do you see such correlation? My second question, Professor, do you think that there's any association between the intracranial pressure with the degree? My last question, Professor, do you think that any benefit of medically induced coma to reduce the case of fast progression by reducing the requirement of oxygen by the brain or by the neuron? Thank you, Professor.
Yes. So let's start off with the first question, is that does intracranial atherosclerotic disease confer a benefit with ischemic preconditioning? I briefly mentioned that in my talk. So people have looked at that. People have looked at atherosclerotic disease with peripheral arterial disease as a marker of ischemic preconditioning. And the data is not very strong. Now, in clinical practice, I know that when a patient presents with a left M1 occlusion with an NIH of 7, I think of ICAD. And when I see somebody with an NIH of 24, I suspect embolism. So I think there is some truth that as you develop atherosclerotic disease with time, you do tend to collateralize further. And that is why in many of these cases, medical therapy has been good enough rather than reconstructing vessels as a cardiologist do. And so that's why Sampras and many other trials failed, because the collateralization that occurs innately in the brain makes these patients behave differently. So I do believe there's a difference. And I do believe ICAD is a complex paradigm of patients presenting. Now, within ICAD, some people develop a plaque and suddenly rupture. So they're less likely to have collateralization. Others that have a progressive narrowing of the artery are probably better collateralized. So I think it's a heterogeneous group within there. Then the second question you asked, or maybe it was the third, and you can go back to the second, is the value of neuroprotection. So neuroprotection is this desired field which has immense promise when you look at rat and mice experiments. There have been hundreds, if not thousands, of studies which have demonstrated a variety of different agents that have significant impact on reducing morbidity and mortality in stroke in animal models. Unfortunately, to date, none have demonstrated the same degree of efficacy in human trials. We recently had the Escape NA1. We were very excited because there was an era in the 80s and 90s, Shigeru would remember, where we had a thing called the Decade of the Brain from 1990 to 2000. And a lot of different trials were funded by the NIH looking for neuroprotective strategies with thrombolytic therapy or just with stroke. 240 different clinical trials, all of them negative. And so we got really excited in 2015 when we saw recanalization having an impact in outcomes to say, hey, what if we still, for example, even when you look at the best case scenario with very good perfusion imaging, look at Extend IA with, almost 75, 80% independence with good perfusion imaging. The good outcome of 0 to 1, MRS of 0 to 1 with complete independence was only 40%. In most trials, 0 to 1 is 20%. In longer trials, 0 to 1 is even less, 13%. And so everybody's got disability. So I think there is real value in neuroprotection. However, the one trial that has been done in the modern era with Escape NA1 using NONO as a protein by Mayank and Andrew Damchuk and Mike Hill with Mike Timiansky in Canada, unfortunately failed to show benefit. So the answer to your long-winded question, my long-winded answer to your brief question is that there is hope, but currently there is no proof that hypothermia, coma, BARB suppression, or any drug makes a substantial impact. But I hope that we'll find one.
Thank you. Thank you very much for that answer. I would like to ask you one question regarding, as you said, time to treatment is the most important thing. But I'm asking about the procedure itself. Once, how many occasions have you failed to revascularize a territory endovascularly, and have you resorted to an open thrombectomy in those cases?
So great question. Our rate of complete failure to recanalize, so that in my opinion is a ticky 0 or 1, is probably in the range of 10%. Okay. And I personally have only done one case where I took somebody with a carotid occlusion and took them for an endarterectomy, but I have never opened the head and pulled a clot out of the MCA, primarily because by the time I get to that 10%, I have tried to stent them. They have integralin on board. They have a lot of different 2B3 inhibitors that prohibit the ability to rapidly convert a failed endovascular case into an open case. So that is the reason I have not converted them to open. But I believe that the failed thrombectomy rate is about 10%.
Thank you very much. Another question, as you mentioned, there are in some parts of the world where they do not go for imaging directly from emergency to the DSA suite. So that's with regard to saving time. How effective or how would you recommend this as a life-saving procedure?
So the problem I have with that strategy is that it is inefficient in terms of using an angio suite, because an angio suite is not a rapid LVO detector mechanism. You need to catheterize access, you need to put a catheter in the head, you need to inject, and so, oh no, this is not basilar, this is PCA, this is carotid, you need to do diagnostic. A CTA is a much more efficient means to detect whether you have an LVO or not. And why I think that matters is that it tells you where the lesion is and what you're going to do and what you come up with a plan. Now, there was a trial, you might remember, called IMS-3. IMS-3 was a failed trial for thrombectomy because patients were just taken to the cath lab directly the way you're describing. That's how the original trial was done in 2013. And mechanical thrombectomy was no better than intravenous thrombolytic therapy in that population. Because into 25% of cases, despite having a high NIH, there was no LVO. And so I believe that this is, so what I believe is based on the Japanese data with a large core and the data that we believe will come out from our standpoint, patients will not require advanced perfusional imaging other than to establish prognostication. Okay, but I think showing the CTA, the occlusion is there, is valuable. So I can tell you the solution we came up with in Buffalo. So what we did was we created a stroke room in the emergency room next to the triage bay. We developed this with Canon, where we put in an advanced CT and a single plane high definition angiography in one room. So what we do is all patients with stroke go into that room for CT. And as soon as we know there is an LVO in a patient, and we do it because we don't want to wait for radiology to tell us and call, we do it with Viz AI, which is rapid detection using AI systems, no human involved. And the AI system sends an alarm as soon as the CT A is done that this patient, before they come out of the scanner, and it's a little complicated, we actually do it with a CTP because we do CTP before CTA. It tells us this patient may have an LVO, an alarm goes out, and the patient's still in the CT scanner, everything stops, CT goes out, angio comes in, patient never moves. And our door to Tiki 3 times are under 30 minutes when we are able to do this. We are still figuring this out, but I've done 3 or 4 cases now where door to recan was under 30. And we got it this year. So I think that may be a really good way of doing it rather than going directly to angio, because poor angio staff, like for example, in our institution, we cover about 2,700 strokes, and we are currently doing about 320 thrombectomies. So it's not every stroke that gets a thrombectomy. So I don't think that's an efficient way of doing it.
Thank you very much for that wonderful piece of information. I think if there are no further, I think there is one question which has popped up in the chat box by Dr. Harshad Parekh, and he asked, did you encounter radiological revascularization is success, but clinically patient has not improved?
Absolutely. It's called futile reperfusion. And we don't understand what futile, I showed you some examples of that. Remember the fast progressors I showed you, where these were patients who had very bad perfusional imaging. They presented within an hour of onset, and we opened them up, and the recanalization looked very good, but the patient infarcted the whole thing because they were fast progressors. So that is one reason. The other reason is that I think there's a lot of distal embolization that is occurring during procedures that we don't really fully account for right now. That's why, I typically tend to use balloon guides as much as is possible for stroke, because I believe that does reduce distal embolization. So I believe both distal embolization and fast progressors are 2 common causes for poor outcome. And then the third factor, again, a very recent, wonderful trial. This is out of Europe, where they used alteplase or TPA intraarterially after good recanalization. Not before, but after. And the outcome, modified Rankin at 90 days, was much better, was significantly superior in patients who got the intraarterial TPA after recan compared to ones before. Again, suggesting that there may be some micro sludge in the capillary bed that is released, that is lysed by embolization. And so I completely believe that there is futile recanalization, and it's a significant reason we don't get good outcomes.
Thank you very much. We can go to our chair to hear his concluding remarks, Professor Miyachi.
Yeah. So may I have two questions from me? It's okay? Yeah. So Adnan, I think you use a rapid system. You mentioned about such an AI system, but if you face best past progress and no time to, very limited time to decide the mechanical thrombectomy. So you decides such an decision making. We only with an symptom imaging mismatch. No, the rapid, and also maybe you directly transport the patient to the angio suite. It's so.
Yeah. So that is, in fact, Shigeru, this is exactly why we built the room for stroke in the emergency room. So our cath labs are otherwise somewhere else in the hospital. That's where the ruptured aneurysms go. That's where everybody else goes. But for stroke patients, because you're absolutely right, the biggest delay is between imaging and intervention. That's the biggest delay in all systems. It's not door to CT, it's CT to revascularization, which is the problem. So that's why we put the cath lab in the CT scanner. So it's one room. So the moment, and what we do is our protocol is this. Our protocol is plain head CT to look for hemorrhage. And then CT perfusion is number 2. And then CTA is number 3. So the way we do that is we take our 4th or 5th volume, our peak contrast from CT perfusion, and upload that to Viz, which is the software. And the Viz interprets LVO based on the CT perfusion injection. And if it sends an alarm for an LVO, then everybody comes to the CT scanner. The team, the nurses, the interventionalists. And so basically what you're doing is exactly that. We're going straight to the cath lab. But it's efficient because we're not doing arterial puncture in patients who don't have an LVO, who have an intracerebral hemorrhage or some other cause.
Okay, yeah. And a second question is, to save the door to growing time, we are trying to skip some processes. And for example, the TPS skip or the MRI skip. So do you agree that such a TPS skip for, and so the directory mechanical thrombectomy is better than the TPA plus mechanical thrombectomy?
Again, a wonderful question, Shigeru. This is based on the SWIFT direct data that we have. There is no significant difference in the two groups. And so one could say that TPA before intervention did not provide value. But there is a trial showing TPA after intervention has value. Now, what we do in our institution is that we give the TPA to the patient on the CT scanner while they're getting ready for the perfusion imaging. So in our system, it does not cause more than a minute or two delay because the TPA is measured and brought and delivered in the CT scanner. It is not given in the ER. The patient's not taken off the CT scanner. It's given and we do perfusion. So we do plain head CT, TPA, CT perfusion, CTA. That is our sequence.
Okay, thank you. So very nice. Yeah, because in Japan, we fail to prove the superiority of the TPS skip patients. So I think I agree with your opinion.
Yes.
Thank you very much. Yeah. So no questions, Roger. It's okay.
Yes, we can move on to the second session.
Okay.
You can give your concluding remarks.
Thank you very much for the opportunity. I appreciate it.
Thank you very much. We are extremely honored by that wonderful lecture and also by the expert comments from Professor Shigeru Miyachi. I would like to mention to all our viewers that this has been broadcasted on WeChat, YouTube and Zoom, and this has been arranged by our Vice President Professor Shubin, and as of now we have 720 neurosurgeons who have joined us live from across the world on all the 3 different platforms. So thank you very much for joining, and it was a wonderful session. So I'll give the session to our second chair, Professor Yoichi Morofuji, to say a short introduction and invite Professor Min-Sing Su.
Let's move on to the second lecture. It's a great honor for me to chair this session. I'm Dr. Morofuji from Nagasaki University, Japan. Today we have Professor Min-Sing Su from the Tongji Hospital of Henzhen, University of Science and Technology in China. Professor Min-Sing Su is doing both microsurgery and endovascular surgery, and he takes care of more than 500 cases annually. Today, Professor is going to talk to us about endovascular treatment of posterior circulation dissecting aneurysms. Posterior circulation aneurysm is one of the challenging fields because of its higher rebleeding rate in the case of the subarachnoid hemorrhage. Professor will present his wide experience about his endovascular techniques. Could you start your lecture when you are ready, Professor Min-Sing Su?
So, good morning, good afternoon, and good evening, everyone. It is my honor to have this opportunity to share our works for you. Today, my topic is that experience of endovascular treatment of rupture posterior circulation dissecting aneurysm. Okay. As far as we know, due to the various reasons, when the blood enters between the middle and outer members, the outer members present a tumor-like protrusion to a form of dissect aneurysm. This physiological progress means rupture posterior circulation dissecting aneurysm have a higher risk of subsequent reblooding and a high mortality rate. So rupture aneurysm of the posterior circulation present a treatment challenge because they have a high risk of complication. Of course, open bypass or clip reconstruction in deeply in location, if it is difficult for most neurosurgery. However, Andrew and his colleague analyzed more than 6,000 cases of the intracranial aneurysm, and they found that the rupture posterior circulation aneurysm treated by endovascular approach, it shows better prognosis and fewer complications when compared with the traditional operation. Moreover, it's offer a less advanced alternative to open operation. In this slide, rupture aneurysm of the intracranial, such as vertebral artery or posterior inferior cerebral artery, are challenged to treat as they are often need to sacrifice the disease segment, which is thought to carry a high mobility to the brain stem and cerebral stroke. However, optional management strategy for this aneurysm is not fully understood. Consequently, they have two main methods to treat this disease, such as occlusion the parent artery, and another method is reconstruction of parent artery. For example, just like this case one, here is an 33-year-old female who suffer from the subarachnoid hemorrhage. The DSA examination revealed there is a posterior inferior cerebral artery aneurysm. We used several coins to embolize the aneurysm. If this method sacrificed the pica, the patient recovery rate without any dysfunction. The case two is similar cases who was also suffer from the posterior inferior cerebral artery aneurysm. The aneurysm is here. So in these cases, we also use the several coins to embolize the aneurysm as well as the parent artery. The patient also recovery very well. So it is very tiny artery. So when we need to deal with the dissecting aneurysm or to the artery stem, how can we do? So just directly occlusion the parent artery and the aneurysm is the conversation method, and which will be sacrifice the disease segment, and it has some risk of mobility to due to the brain stem and the cerebral stroke. For example, if we need to focus on these difficult cases, we can't occlusion. We can't occlude the parent artery and the aneurysm. For treatment of, especially for treatment for the dissecting aneurysm, we should not to embolize the parent artery too hastily. So today the key point is how to reconstruct the parent artery and how to protect the disease segment. Let us focus on the the cases we have reported. If the artery was in the stem of the artery, just like this case, he is a female who was suffer from the basilar artery aneurysm, and so it's the rupture. How can we deal with? As far as we know, reasonable application of the stent can prove the efficiency and safety during the operation. It can not only improve the embolization efficiency, but also to reduce the blood flow to the aneurysm and alert parent artery aggregation. So they have so many advantages to help us and to finish the endovascular treatment. I will share with you the typical cases. The cases 3, just like I told you. Here is the basilar artery aneurysm, and in these cases, it's a normal cases. We use the enterprise 2 stent combined with the several coins to deal with, and the patient was recovery very well. The aneurysm was remote 1 grade, and this is case 4. Is a 61-year-old male patient who was suffer from the posterior inferior cerebral artery aneurysm. The difficult of the endovascular treatment is how to protect the pica and completely embolization of aneurysm, because it is the origin of the pica, the aneurysm was very dangerous, and the patient was the emergency patient who was suffer from the subarachnoid hemorrhage. So in these cases, we use two stents combined to form the H shape to deal with. First of all, the microcatheter SL10 was crossed aneurysm and to the pica. And this microcatheter is for release the stent. And then the headway 17 was filled the coins, the prime, cosmos, target, and so on. Then the atlas was released, and we can find that is the pica, and the atlas released from the pica to the ventral artery. And the next step, we continue to fill our coins, the prime, in the neck of the aneurysm. Then we use the infusion catheter cross the atlas stent, and then to release the second stent, the enterprise 2. Finally, the last coins was also filled in the neck of the aneurysm. Here is the steps of the operation, how we deal with these difficult cases. We can find that the two stents combine to form the H shape, and there is no sacrifice of the pica, and the aneurysm was remote 1 grade. The patient was recovering very well. This is the case 5. The patient was who was suffer from the basilar artery aneurysm. This case is not specially for our operation. We want to share with you because in this case we can find that with the stent, the stent not only can help us to improve the effective of the operation, but also can stimulate for the microcatheter, because we release the stent first of all, and then here is the microcatheter to use to fill the coins, and then it's very easier to fill the coins at this location or of the artery and the aneurysm. We can find that from these cases, the stent not only can improve the embolization efficiency, but also can stabilize the microcatheter and easier and safe to get remote 1 grade, and the patient also recover very well. This is a case 6. The patient who was suffer from the posterior inferior cerebral artery aneurysm, and is the emergency cases. The pica is very tiny because the post-contralateral the vertebral artery was very tiny when compared with this side. So first of all, we try to protect the pica, not to sacrifice this pica first of all. So we try to use the atlas stent and combine with the microcatheter SL10 to fill the coins. With several coins, the aneurysm was dealt with very well. And here is the DSA examination post-operation. We can find that the aneurysm was remote 1 grade, and the patient recovering very well. And 6 months after operation, and the pica is still very good, and the aneurysm was this period. From these cases, we can find the role of the stent have several positive functions, such as it can help to occlude the aneurysm neck and stabilize of the microcatheter system, and moreover, it also can improve the efficiency of the operation. And here is some publication of the stent, but those cases was the overlapping technique. So in our daily route, we also use this technique to deal with our emergency cases, especially for the posterior inferior dissecting rupture aneurysm. For example, the case 7 is a male patient who suffer from the basilar artery aneurysm. We can find that the aneurysm is here, and in these cases, there are several coins or embolized into the dissecting aneurysm, and moreover, we use the IVs combined with the enterprise 2 to reconstruct the pulmonary artery. Pre the operation, we can find that this artery is not good, but post is during the operation, and post operation we can find that we almost to reconstruct the artery again, and the aneurysm of this period is remote 1, and patient recovery very well. In these cases, we use the Elvis plus the enterprise. The two coins was overlap, and the case 8 is a 12 years old child who suffer from the posterior cerebral artery aneurysm. Is also an emergency cases. During the operation, we release the atlas stent first of all, and then we cross the atlas and to embolize the aneurysm. And several soft coins were performed to the aneurysm. Finally, we use the Leo baby. We can see that we use the Leo baby was released for overlapping the atlas stent. With the DSA examination after operation, we can find that the dissecting aneurysm was remote 1 grade, and the child was recovering very well. The case 9 is a normal case. It's a normal dissecting aneurysm of basilar artery. However, I will show this case to you because during the operation, the dissecting aneurysm was ruptured again. And this case is just like I told you, this case is where I want to show that the body of the dissecting aneurysm is very, very weak. Fortunately, we didn't lose when the aneurysm was secondary rupture. We also use the soft coins to deal with the secondary rupture. And the step 1, 2, 3, we use several soft coins. And when we finish the operation, the aneurysm was disappeared. And here is the DSA examination post-operation. In this case, we use the enterprise 2 overlapped Elvis stent. Also, we also deal with the secondary rupture during the operation. And here is the 3D information, and the pre-operation and the post-operation. The aneurysm was this period, and it's a remote 1 grade. From these cases, we can find the role of the overlapping stents have several advantages for treatment the dissecting aneurysm, including reduced blood flow to the aneurysm, alternate parent artery aggregation, reconstruct the parent artery, and improve the effect of endovascular treatment. For example, here is the pictures of the pre-operation of the dissecting aneurysm. Here is the dissecting aneurysm, and here is the stem of the artery. When we released IVs overlap the enterprise, we can see that the artery, just like the reconstruction game, and the aneurysm was this period. And this picture also can prove the overlapping stent technique is very useful for those special rupture aneurysm. And this case is the patient who suffer from the posterior cerebral artery aneurysm. In this case, we should not directly sacrifice the posterior cerebral artery, certainly, because the aneurysm was in the region of the posterior cerebral artery. So in this case, overlapping stent technique was performed. We can find that, first of all, the enterprise 2 stent was released at the first stamp, and then the microcatheter SL10 and Highway 17 was crossed enterprise 2 and into the up and mouth of the aneurysm, and several coins was filled in the aneurysm, and such as the target, prime, and VFC. Then the IVs stent was released for overlapping the enterprise 2. With the DSA examination, we can find that the pre-operation and the post-operation, the dissecting aneurysm was Raymond 1 grade, and the patient recovering very well. This case is also no special case of the dissecting aneurysm. The female patient who was suffer from the ventral artery dissecting aneurysm. We can see that is also the emergency cases, because today our key points is emergency rupture dissecting aneurysm, and we can find that the ventral artery is tiny, and here is the aneurysm. We also use the stent combined with the coin. After the enterprise 2 was released, we also can see the aneurysm body. But when we release the LVO baby, the second stent, without any coins, the aneurysm was in this period. And these cases was proved the effective of reconstruction of the artery, where the stent was overlapping released. The no matter, however, is the enterprise plus enterprise, or enterprise plus Elvis, or LVO baby, or Atlas, and so on. And we can see that post-operation examination. Here is the aneurysm, and here is the parent artery, and we use the enterprise overlap the LVO baby, and here is the aneurysm. Here is the parent artery. The parent artery was not sacrificed, but the aneurysm was this period, and the patient recovering very well. The case 12 is a patient who suffer from the basilar artery aneurysm, but the aneurysm is very huge. The case is we also perform the overlapping stent technique. We use the enterprise overlap enterprise, and these two stents also can help to reconstruct the parent artery with the information of the DSA examination post-operation. The dissecting aneurysm disappeared, and the patient recovered very well. The case 13 is a child who was suffer from the basilar artery aneurysm. It's also the emergency cases. And it's very huge, the value of the aneurysm, but it's a child. So in these cases, the overlapping stent change the blood flow and reconstruct the parent artery, and we can find from the information of our operation. Because the patient was child and also suffered a serious subarachnoid hemorrhage, so we did not to choose the flow divert to avoid the loading dust anti-arrhythmic drug post-operation. And if we use the flow divert, we're afraid we can't to embolize the aneurysm very well. So in these cases, we use the longest size of the enterprise stent and the overlapping and the second enterprise too. And from the DSA examination, we can find that the patient was recovered well, and the aneurysm was removed too. Is also good. The next case is a patient who suffered from the posterior cerebral artery aneurysm. In these cases, we certainly should not directly sacrifice the posterior cerebral artery. And even if it's not in the origin of the posterior cerebral artery, we also should not to sacrifice this artery. In these cases, we also use the overlapping stent. The Enterprise 2 was released at the first stamp, and then SL10 and headway 17 was across the Enterprise 2 into the aneurysm, and several coins such as Target, Prime, and Cosmos VFC was filled into the aneurysm. Then the second, the Enterprise stent was released for overlapping the first stent. With the DSA examination, we can find that the aneurysm was remote 1 grade. And here is the information of the 6 months later. We also can find the posterior cerebral artery after half a year of the endovascular treatment. From these cases, we can find the role of the overlapping stent, which include reconstruction of the parent artery and blood flow. Moreover, this strategic approach could achieve the effective of physical therapy. Several researchers report that the method, but in our hospital, we sometimes, first of all, we release the first stent and then to fill the aneurysm. But in other cases, we also in the first stamp, we fill the aneurysm and then to release the stent. Both of two methods is okay. From the paper, which publication with other researchers, they found the IVIS plus enterprise. The IVIS plus enterprise has a high matter converge ratio, which means a higher effect of the blood flow. So as far as we know, if we want to have a great progress of the dissecting or a giant aneurysm, and the endothelial cell overgroup is very important. So if we use the overlapping stent, it's easier to achieve the effect of physical therapy. That means the endothelial of the artery is easier to overgroup, and it can be reconstruction of the artery. So there are publications which use the flow divert for the rupture posterior circulation. And the complication rate of the posterior circulation is significantly higher than that of the arterial circulation aneurysm, which was used flow divert. However, in our center, we prefer to use overlapping stent technique to deal with the dissecting aneurysm, especially in posterior circulation, because this method could be easier to embolize the coin into the aneurysm. And it can also achieve the effect of reconstruction of the parent artery and blood flow. In summary, we thought that the application of the stent can play an important role in treatment of rupture posterior circulation dissecting aneurysm. The application of the stent has an advantage in treatment of the irregularly aneurysms. So another reason is for aneurysms that are difficult to be treated by conventional method, especially for the irregularly aneurysm and the dissecting aneurysm. Overlapping stent technique can play a role in the vascular as well as blood flow reconstruction. The key point is reconstruction of the artery and the blood flow. The last but not at the least, the flow divert for rupture posterior circulation dissecting aneurysm also can be considered an alternative option. Thank you for your attention. Thank you.
Oh, thank you very much for your wonderful lecture. You shared many cases of ruptured posterior circulation dissecting aneurysms. We've learned a lot from your excellent lecture. Now we're open for discussion. Any questions and comments from audience or web?
So far, there are no questions. Professor Shigeru Miyachi is still with us. Professor Miyachi, any comments from you?
Yeah. So Professor Zhu, it's a very nice lecture. Thank you very much. And I agree with your strategy for the so difficult posterior circulation aneurysm with stenting. And but I have a question. In ruptured case, acute ruptured case, what is your protocol of so antiplatelet agents in the rapid rolling of antiplatelets after stenting? How about your strategy?
So you means how to anticoagulate drug?
Yes, antiplatelet drug.
Yes, antiplatelet, aspirin or the
before the operation, we are not use anything of the anticoagulated drug, but when we have finished the operation, we use the loading dose. That means 3 microgram plus 300 microgram the aspirin and lubricating, and then it's lower. The level is much lower than the flow divert, but it's just the normal stent for the emergency cases. And
you after the procedure, you inject such an agent, not during the procedure.
Yes, we use in the tilofiban. I can
Yeah.
tilofiban during the operation. And it's combined with the loading dose anti-congruent drugs after operation.
Okay. Thank you. I understand it.
You're welcome.
Morofuji.
Any other question? Oh, okay. So I have one question. So in cases of ruptured vertebral artery dissection, kind of like without involving pica, so the pre-pica or post-pica aneurysm, are there any cases that you selected the parent artery occlusion of the vertebral artery? I'm asking because when I formed the stent-assisted coiling for ruptured vertebral artery, I keep worrying about the regrowth of the dissecting aneurysms. So even the occlusion seems complete. So I mean, after the stent-assisted coiling, so do you have any cases of the recurrence of the aneurysm or regrowth of the aneurysms after the stent-assisted coiling or overlapping stent for vertebral artery of aneurysms?
I'm sorry, I didn't understand.
Okay, so do you have any cases of the recurrence?
Recurrence.
Recurrence or regrowth of the dissecting aneurysms after you perform the stent-assisted coiling?
Yeah, I can show you. For example, can you see the slides?
Yes.
Yes. Now
for example, this ventral, you mean the ventral dissecting aneurysm? Just like, this cases. Here is the pica, and here is the aneurysm. These cases we use the stent to stabilize the microcatheter of the SL10, and then we release the stent firstly, and then to fill the coins. And here is the pica, and here is the parent artery. It's not sacrificed. Also, we have several, just like in the cases. For example, these cases, can you hear the slides?
Yes.
Yeah, it's also the ventral artery dissecting aneurysm, and but unfortunately, it's a rupture during the operation. It's rupture again, and but the microcatheter of the coins we also stayed into the aneurysm, so we choose the soft coins and use enter and back and enter and back, and the dissecting aneurysm was deal with very well. And here is the post-operation information. And in these cases, we also did not sacrifice the ventral artery. So in the emergency, for those emergency cases in our center, the first choice of us is to just to analyze the aneurysm and the reconstruction of the parent artery, but not to sacrifice the parent artery.
So you mean if the vertebral artery is the non-dominant side, you selected the stent-assisted coiling, right?
Yeah, if we have no method to deal with the difficult cases, we have to sacrifice the parent artery. But the first choice is not, is to protect them.
Okay, thank you.
Thank you, Professor.
Thank you very much. I think it's time, because there are no further questions. We can wind this up after hearing the expert comments from Professor Morufuji.
Okay. Thank you again, Professor. The professor shared the cases with ruptured dissecting aneurysm treated by stent, especially stent-assisted coiling or overlapping stent. So in Japan, so we cannot officially use the stent for ruptured aneurysms in acute stage because of our insurance system. We sometimes use, but so we learned a lot from your lecture. Thank you again for your wonderful lecture.
Thank you, Professor.
Thank you very much. We all learned from that wonderful session and it was very useful. And I will wind this up officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito. I would like to thank both the speakers of today, Professor Adnan Siddiqui and Professor Mingxing Zhu, as well as the chairs, Professor Shigeru Miyachi and Professor Yoichi Morufuji, for the time and support for the ACNS webinars. I would like to express my sincere thanks to Professor Shubin for broadcasting this on the WeChat channel. And as of now, today we have around 720 people who have joined us live. A special thanks to my co-host Libun Singh for joining in me today. So until we all meet on next week, it is bye-bye from all of us. Thank you very much for joining.